Thank you so much for including me. I'm very happy to be here, and I wanted to let you know that the information pertaining specifically to physical therapy for men is summarized in the section online through the ICS for this workshop. And I was just going to elaborate on that, and I decided to change direction. And I thought I would talk about evidence in general and use male pelvic pain and the literature to date, very limited, to illustrate this point. My disclosures include our private practice, Vista Urology. I also want you to know that I am the co-author of the PT trial, just to disclose one of my many biases. And I also want you to know that when it comes to the publication of work in this field, I am somewhat of a skeptic because there is kind of like a prostatitis mafia that I think exists. So that's my bias. So evidence-based practice should be conscientious, a problem-solving approach to clinical practice that incorporates the best evidence from well-designed studies. It should involve what patients value in their preferences, which would imply that the patient is informed and educated by us, and the clinician's expertise in making decisions about patients' care. But remember, we're trusting publications for the most part. We're trusting what our colleagues are putting in print. But we have to remember that if you torture the data, it will confess. And that means that you can manipulate data in so many ways. You can exclude studies, you can embellish certain things, you can alter the statistics. A statistician at the Cleveland Clinic once told me, "Don't be intimidated, Jeanette, by all the fancy statistics." I'm not a statistician. And you sometimes get all caught up in like, oh my God, they did a chi-square and then they did this, other program to do the statistics. He said to me that if you understand basic statistics and you publish your papers using basic statistics, you have nothing to hide. Be very skeptical of all the fancy things that tend to intimidate us when we read them, so we take them as fact. This also implicates our own theories and biases, so we have to be careful about how we look at the literature. I confess that if something is leaning towards my theory and it validates me, I love to read that, and I may decrease my level of scrutiny. On the other hand, my antennas go up for something that I disagree with, rather than being open. So if you don't have time to review the literature in an in-depth manner, I would ask you just to begin by picking something that totally validates you and wear a different thinking cap when you read it, like read it very critically, and then look at something that you would disagree with and try to read it with a more open mind. So this is probably the biggest ingredient of evidence that I think gets overlooked. It's like, how do we, take the time to do this? So I'm going to spend a lot of time, mostly as a skeptic, looking at this article that was published in the European Journal of Urology in 2016. The title is very authoritative and very attractive. It's The Contemporary Management of Chronic Prostatitis and Chronic Pelvic Pain Syndrome, with some big name authors too, so you get a little bit of the cult of personality. Don't forget also that this is a high impact journal. So if you're a busy practitioner, you're like, I'm gonna go to the high impact journal, I'm going to look for a review article or a meta-analysis, and I'm good to go. I probably don't have to read anything for another year. And you're probably already doing better than the average, practitioner who it doesn't even have interest in this area. But here we go. This particular paper did a review of 28 randomized controlled trials, and they met the criteria because they all included the CPSI, which is the Chronic Prostatitis Symptom Index. That definitely helps to facilitate the analysis because you're dealing, apples with apples rather than apples and oranges when you're interpreting the results. But one of their conclusions that's very eye-catching after reviewing 28 randomized control trials which includes all of the 3As, the antibiotic alpha blocker, anti-inflammatory, the immune modulators, hormone agents like finasteride, phytotherapies, and finally the physical therapy. They conclude that all of these options fail to reveal a clear therapeutic benefit. So they use this as a platform to promote phenotyping, which is exactly what we need. A lot of the studies that were even done prior to our NIH study that showed no significance or any benefit, it may have not been that the modality was not beneficial. It was that patients were included with a very broad net, and our physical therapy paper or study was very precise in about who was included. But then this is lost. This is a contemporary paper, supposedly, and yet it persists in applauding the NIH prostatitis classification system, which needs to be eliminated. It also does too much hurrah for the CPSI. Not only does it still contain that word prostatitis, which continues to perpetuate bad information, erroneous approaches to the patients, but it also has other limitations. For one, a consensus had determined that to confirm that a study was of benefit, there should be a 6-point decrease in the CPSI at the end of the trial. And what that does is it causes investigators to recruit patients who have more severe symptoms so that they can actually achieve that 6-point drop. So now we're excluding maybe the patients that we have with moderate disease, and we're using a different criteria rather than percentage points, like proportional improvement. Also, a lot of the studies fail to acknowledge the GRA or other quality of life measures that could be significantly improved, and they focus only on this. And finally, at the end, in this paper, they resurrect the idea of differentiating patients according to the presence or absence of inflammation in expressed prostatic secretions. This is extremely ridiculous, especially because the authors, one at least in this paper, has also co-authored papers long ago completely refuting the relevance of inflammation in pelvic pain. It only matters in acute bacterial prostatitis, and it may matter in asymptomatic prostatitis when we're dealing with conditions of infertility or premalignancy, and that's yet to be determined and panned out. The NIH prostatitis classification system, just to remind you, is this, and it even has a special chart in this paper. Category 3, which is really chronic pelvic pain, it is not prostatitis, was divided at one time into the inflammatory, non-inflammatory, and culture was that if it was non-inflammatory, it was prostatodynia, therefore the patient should just be referred to a psychologist. There is nothing more ridiculous than this, than the encephalitis classification system, which I invented only to prove how bad this system is. Imagine if you had headache under an encephalitis classification system. No one would ever accept this. Can you imagine that you wouldn't even know what kind of headache? A cluster headache, a migraine headache, a tension headache. There are so many forms of headache, just like there are so many forms of pelvic pain. That should be the overarching classification system. And imagine if we used type A, spinal tap positive, and type B, spinal tap negative, or encephalodynia. I also made that up. So, this would be completely wrong. And yet this was wrong 20 years ago when it was published, and it's even more wrong today. And a 2016 publication in the European Journal of Urology is still perpetuating this. Chronic non-bacterial prostatitis, even written in that consensus paper of 1996, those authors stated it's never been proven to be caused by an infection, not even a disease of the prostate. And it still hasn't, by the way. So it may take a few more years for the ship to turn. And then here, I know it's difficult to see, in the same paper, we're being asked to accept the U-point phenotyping, but also with category 3A prostatitis and category 3B prostatitis, which has no relevance whatsoever. Again, same authors years ago proved that whether you used semen, expressed prostatic secretions, or VB3, if there was white blood cells in those specimens, it had no correlation whatsoever with the patient's symptom or with the patient's lack of symptoms or progress. This is just horrible to me. And this paper, in summer, I think perpetuates not only outdated standards, but standards which were poor from the start. Let's look here at the physical therapy trial, which they give a no. They say it's not significant. It was significant when we published it, but I'll explain why that happened. But also see in this column is the point change. And you could see that the change in the CPSI, for many of the studies, 7, -4, -3, our study was -14. And yet that's not even mentioned in the paper. It was just like, well, this was our criteria, that's the cutoff. It's the largest change that had been seen, and it was the only positive study during the cycle that we were involved in. It was a multi-center trial. 49% of the patients recruited were men, and they were all eligible because they had a physical examination to phenotype them. At the time, we didn't use that terminology, but we were indeed phenotyping. And we randomized them between manual physical therapy and global therapeutic massage. The improvement in GRA was statistically significant, even though the study was only powered for feasibility. It wasn't powered to compare anything. It was just to see if patients would be able to endure a 10-week trial. But the treatment response by gender was surprising. Men had incredible, compared to women, incredible response, to the manual therapy, but also to global therapeutic massage. Women did not. So what they did for the purposes of this paper was to sub-analyze this group, which is justified, I understand. But there's something so intriguing about this group, and it's compelling enough to promote more study, promote more questions, and not to paint it in a negative light. So then let's look at alpha blockers. Those are all in this area. There are very small numbers in these trials for the alpha blockers. All the small trials have a yes in terms of significance, but very little attention is made to the study up here, which was supposed to be the end-all, be-all for alpha blockers. When I had joined the research group, this study was about to begin, and I very naively and negatively asked, why are we doing yet another alpha blocker study using American tax dollar for such a study? And they said, no, this is going to do it. This is going to be the best study. It's randomized control, best practitioners, multi-center. And indeed, this is a really large study, 272 eligible patients. If you put this into a meta-analysis, this completely changes anything. I mean, it would make the use of alpha blockers a complete contraindication in this setting. You could see what happened during this research cycle, that when they compared treated patients with controls, the degree of improvement was exactly the same, and the p-value was 0.99. You should have seen the faces in the room when this was revealed, because everyone was looking forward to like alpha blocker being the new cure for prostatitis. Then this brings me to pregabalin. And I'm trying to illustrate to you how misleading these things can be, whether they're negative or positive. Pregabalin is a neuromodulator, and they get a no because the statistical significance was 0.07. But let me tell you a little bit more about that study. They had 218 patients to 106 controls, a 2-to-1 randomization. This is a huge, huge study, relatively speaking, and it cost a lot of money. And as an American taxpayer, I really resent this because it was done improperly. They ramped up patients on this medication to 150 to 600 milligrams a day over a 4-week period. Those of you who know this drug, pregabalin or Lyrica, know that we started at 50 milligrams. We ramp it up very slowly, and a lot of people take weeks to get to even 300 milligrams a day, 150 twice a day. So they ramped this up on 4 weeks based on a herpetic trial, a herpes zoster trial, and then they ended the study at 6 weeks. In real life, we never prescribe a neuromodulator and judge the efficacy until we've ramped the patient up and then followed them for at least 6 weeks. So that would be that, you'd have to do a minimum 12-week trial, but you're very comfortable saying this is a negative trial because the 6-point change was not significantly different. However, if you look at all the other parameters, quality of life, GRA, BAS, they were all less than 0.05. So if you're a novice in this area, you would think, well, I'm never going to use pregabalin on one of these patients. Well, that's totally wrong. With regard to all the neuromodulators, we follow the same rule, and we try to, again, ramp up accordingly, individualize the care, and then give a really reasonable trial period before we discontinue or try ramping up again or changing the neuromodulator. This is a study that I found. It's a retrospective study looking at gabapentin, which is the predecessor of pregabalin. And this is just following 119 patients in a closed system. And they found that 75% of the patients had a greater than 50% improvement with gabapentin alone. And so apparently it worked better in this study than the pregabalin. We use both, but as my partner, Dr. Payne, reminded me, we usually use the gabapentin first only because insurance companies pay for it in the United States. But gabapentin is a hassle to ramp up, and patients usually have more side effects. So again, we just have to be careful, and this is just one study. But the take-home message here is that there is a place for neuromodulators in your practice. And then here's a promising highlight from this paper, which I'm ashamed to admit I didn't know about. In fact, I had been asked to review the paper, and I didn't review it. I turned it down because I was too busy. And that's extracorporeal shockwave therapy to the perineum. And this is a yes, statistically significant improvement. This is their algorithm. Please try to ignore the part that upset me greatly, was that the inclusion criteria was that they failed the 3 A's. Again, here we are in this day and age, and we're still perpetuating the 3 A's because yet of another bad paper that came out 5 years before this one. And they also tried, for whatever reason, to insinuate the U-point system. There are so many papers now that insinuate this with, again, no significant bearing on the study, the purpose, or the outcome. That being said, they did recruit these patients, 33 of them, and they followed them for a total of 12 weeks. And after only 4 treatments, which were given 1 week apart at low dose, they had significant improvement. I couldn't find any holes in their procedure and their findings. The rationale for this is coming from other fields, primarily muscle rehabilitation after injury, and they've proven that this form of shockwave therapy can induce neovascularization. We know that's good for the pelvic floor. It has an anti-inflammatory effect. It can interrupt nerve impulses, kind of like neuromodulating. And it's been shown to reduce passive muscle tone. And they also believe that it can influence neuroplasticity of the pain memory, again, like kind of a neuromodulatory effect. However, in the study, they don't tell us what was the pelvic tone. What did they find on digital rectal examination? Were there any other, any evidence of any other pathology? Well, this is a review of other studies done using this shockwave therapy. And again, I admit my embarrassment, there's quite a number of them. And the one that I'm most impressed with are the series by Zimmerman. He and his group in Austria did 2 pilot studies, kind of testing out the technology, and then went ahead and did a randomized controlled trial. And again, 1 treatment, 4 weeks in a row, 4 weeks total, and then they have a 24-week follow-up, I believe, with very good results. So what this illustrates, and we can do this probably with a lot of different papers, is that you have different practitioners just trying to guess what's really going on with this whole person. They're just trying to break it down to their tool or their tunnel vision. And we still don't know what we're doing, and probably it's best to summarize that our evidence is poor. After 20 years, we still have publications citing the 3 A's as first line of therapy. For all the talk of the U-point and phenotyping, those papers do not take us away from the organ-based diagnosis. That was what we were trying to do, is get away from the organ-based, get away from the prostatitis classification system. And now we're heading in the wrong direction again. They don't acknowledge a physical exam to rule out myofascial trigger points or connective tissue contributors. They don't rule out neuropathies. They just say neurology, neurologic, neuropathic pain, but there's nothing in there about an exam to look for a Tinel sign for the pudendal nerve, nothing to look for the posterior femoral cutaneous, the hypogastric, the ilioinguinal, nothing like that. And they continue to use the word prostatitis, chronic prostatitis or CP, or the CPSI verbiage. And I submit to you that that is just perpetuating, again, a hindrance to our care of patients and to research. Pelvic pain syndrome is the way we need to look at it. It's multifactorial, and oftentimes there's more than one condition occurring at the same time. So it's mostly overlapping in real life, real clinical settings, so we have to do a better job of phenotyping, and that means that we can't get away with laziness. We have to really ask the researchers who are doing this to step up to the plate and actually perform a physical examination before they recruit the patient, instead of worrying about meeting the criteria for recruitment so that they're eligible to get the grant money for the next cycle. There I go. I'm cynical and skeptical, but I've seen it. So what's new since this study? There's this Botox study looking at transurethral intraprostatic injections, 48 consecutive patients, a 22-point reduction in the CPSI. And that's very impressive. And they do, say that after 9 to 12 months, this reduction wanes, just as we would expect with Botox. Great study. I'm very excited. The only thing is I don't understand why they chose to inject that area. And I think it would be really wonderful to have a better understanding of the targets we should use for Botox, instead of like templates that have nothing to do with the patient's actual physical examination. And then there's a lot of work coming out now on ganglion impar blocks. And I know in the Silicon Valley area that this is becoming widely used for all types of pelvic pain. And there are 2 studies I found. One is a series with 31 patients from India showing that a 7 out of 10 or 8 out of 10 pain scale at the initiation was immediately reduced to 1.26. And then at 24 weeks, it just bumped up a little bit. And most of the patients in this study had fallen, so there was trauma to the coccyx. I shouldn't say most, but nearly half. The Leclerc study from France involved 83 patients and 220 blocks because, as you could see, the majority did have 3 blocks. But they showed that there's only transient relief, which they defined as 50% improvement at the initiation, and then it was not sustained in more than half. So 41.6% improved at 1 month, and again, improved 43% after 3 blocks. I think this is a very good start, but it would be wonderful again to know what phenotype are we talking about for this type of block. Yesterday in a workshop that I had the honor of participating in, Doctors Day and Argoff presented their preliminary data, their first paper on small fiber polyneuropathy. As you know, I'm a big believer in central sensitization, but even then, you hit a block, you hit an impasse, and we can't get these patients better. So this was very illuminating to me. I learned this for the first time. And they showed that among 39 CPPS patients who had refractory symptoms, or they had the presence of systemic conditions like IBS or TMJ or other types of things that are considered functional somatic syndromes, that 25 of them, or 68%, showed decreased intradermal small fiber neurons, neuron density, which is diagnostic for this condition. And then it opens up a whole other arena for randomized controlled trials for treatments. So looking ahead, how do we create better evidence? We need to pay attention to words. We need to stop saying and writing prostatitis. I kind of want to call it Voldemort. It's the Voldemort of urology. I don't want to hear it. I'd like to see that we expand the trials that are positive. We should really expand that PT trial that we did. I'm sorry that I didn't apply for a MAP, and I'm sorry that the people who were going to expand the trial were not awarded a MAP grant. I'd really love to see what the extracorporeal shockwave therapy looks like. I really would like to replicate that and see if we can do a multi-center trial. I think that's really exciting. It's very costly and cumbersome for patients to have, a lot of sessions of PT. I'm not saying anything against PT. I'm just saying we could be open to this at the very least as an adjunct. Instead of the 3 A's, we should only allow randomized controlled trials in which the researchers are willing to actually do a physical exam. And I really mean that. Instead of 3 A's, maybe we should study the 3 P's. We could create a new system that we use as an inclusion-exclusion criteria, a trial of physical therapy with pregabalin and with psychotherapy. Why are we still stuck with 3 A's, which are more prostatocentric? We need to improve the inclusion criteria for the ganglion impart trials. We need randomized controlled trials for Botox, especially for men. And we also need the same for the pudendal nerve blocks and the posterior femoral cutaneous blocks. Our own due diligence is the following, and I'm reading this to myself. I feel I should pin it to my mirror in the morning. We need to actually keep up with our reading. We need to read critically, especially when it comes to methods. We need to write letters to the editor. Like, who lets this stuff get published? It's the same old guys reading this stuff over and over again who pass it through. I'm sorry, that's how I feel. Be a reviewer. As I just admitted, I turned down reviewing that paper because I was too busy. I genuinely was, but now I regret it. I regret it not only because it's a good paper, I'm embarrassed not to know it. Other times I regret not reviewing things because they should not have gotten published. And then finally, watch for trends in your own practice. We're all caregiver scientists. We're all supposed to keep tabs of what we're doing. So try to notice trends, and if you can, set up a little 6-month prospective pilot. At the very least, it will help guide your way of practicing, but even more, what if it could get published? What if it could lead to a randomized controlled trial? So that's the end of my talk, and thank you for allowing me to deviate from the original plan.